Okay. I want to thank everybody for sticking through to the end to listen to this. So what I'm going to be talking about is basically diffusion of contagion over very large social networks. And most of this, the computing work, has been done by my grad student, soon-to-be former grad student. All the modeling work has been done within our lab over the past about 10 years. So there's a lot of stuff that's gone on, and I don't want to claim that I'm the one who's done the majority of this work. So what is the problem? We want to spread a contagion across a large network. And by large, we're talking about somewhere between 300 million nodes and 8 billion nodes. That comes from the population of the world. So that's the target, and we feel that the main problem with getting there is generating the data. We should have that in the next year to 18 months. So you can do this with a lot of different contagion processes. What I'm going to be talking about mostly is influenza, but we've also done smallpox and pertussis in the disease realm. We've also used this to do things like the spread of rumors and fads, social contagion, things like smoking, obesity, incarceration, and social unrest, and things like computer malware, viruses spreading through computer networks. And the overall goal of this work is to evaluate different types of interventions to either slow down or speed up the spread of a particular contagion. If it's a disease, obviously you want to slow it down. If it's something like spreading information through society, and for example, for marketing, that might be something you want to speed up. Find the key people that you want to get your message to, who will then spread it to other people and have things spread through society. So like I said, most of what the rest of this talk is going to be specifically on computational epidemiology. So why do we want to study this? There's 13 million deaths a year from infectious diseases in the United States. You really can't do controlled experiments. You can't pick a group of people to vaccinate, say, and another group of people not to vaccinate, and see how they fare. The IRB people won't let you even propose something like that. Another thing you can't do if you're just doing things experimentally is actually find out who was the origin of a particular disease, who they came in contact to, what the actual transmission pathways were. So you can't find out who is responsible for the spreading, who you should go and vaccinate. And then we're also using these pervasive computing environments to get new surveillance data. Surveillance is a very hard thing to do. Surprisingly enough, medical surveillance is not very accurate. It has very low reporting rates, and the time delay on it is fairly high. So some of the things that you can do with this is forecasting. So predicting into the next few weeks or a few months what the flu season is going to be like, and not just overall, but for specific subpopulations, specific geographic areas. Course of action analysis: while you're in the middle of a pandemic, what should you do? Who should you vaccinate? If you have a limited stockpile of vaccines, who should you give them to for maximum protection? And an interesting result that we've come up with, or actually our collaborators have come up with, is that if you have a very small number of vaccines and you're trying to protect the elderly population, who are the most vulnerable, it's actually better to give those to families who have children, protect the children, because those are the people who are infecting the senior population. Once you get above a certain threshold, then it's better to go and vaccinate the seniors. And then another one is situational awareness. Just what is the current situation out there? You're at the very beginning of the epi curve. Just a few people are sick. Is this something that's going to take off? Is this something that's going to just kind of bounce around for a while and not really infect a lot of people? And then preparedness and training beforehand. training the decision makers to know what questions they're going to face and potential responses to things. So just a brief summary of how we generate the populations. This question generally comes up, and this actually goes back to the GIS stuff. We use a lot of GIS software to do this. Basically, we take census data, streets data, a whole bunch of data stuff. In a big data fusion process, we generate a synthetic population. So these are not individual identifiable people. These are a synthetic population where if you took a census of that population, you would get matching results to the US Census or to another country's census. Each one of those people has a list of things they're going to do during the day. We do location assignments, so we know specifically that I'm going to go to work in my Blacksburg office and then go to lunch at a particular restaurant, go back to my home. So basically from that we know minute by minute throughout the day where every person is and who they're coming in contact with. And then from that we infect a few people and then just watch the disease spread through the population as people come in contact with each other. So this is just a summary of what we're doing. Here we have a sample disease model, a within host disease model. Some of these are, this is a simple example, some can get more complex, but people start out as uninfected. They can go to either a symptomatic or unsymptomatic state. I guess those are over here. And then eventually they recover. So once a person gets infected by coming in contact with somebody else who's infected, then they take a probabilistic path through this automata. And then up here is how we calculate the probability of somebody getting infected. It basically depends on the time of contact and the infectivity and susceptibility of the two people. So what we're doing, so this is an agent-based model, obviously. We have a realistic population. We do complex interventions. So in addition to the simple things like vaccination and school closure, work closure, we can do things like a certain fraction of the population, when they get diagnosed, will start taking Tamiflu, which reduces their infectivity to the rest of the people. We can also do things like self-isolation. If you're worried about the flu, instead of going out and doing things with people, you stay at home. And that can be dependent on your individual demographics, your age range, your income, whether you're single or in a family, etc. And all of these things interact. So you have a contact network, who you see during the day, your individual behavior, public policy, and your individual health. Any one of those can affect everything else. So if you get sick, you stay home instead of going out, and that changes your contact network and everybody else's contact network who you're with. Depending on the state of the flu around you, you may decide to stay home or not. So just a few things about what we've done in the past. We started this work actually in about 2002. We've dealt with influenza planning, so dealing with decision makers, government decision makers, to inform them on how they can best prepare. What types of questions, what decisions they're going to have to make, what information they're going to have available. In 2009, I'll talk about this a little bit more, but we were involved in the very early days of the emergence of the H1N1 virus. Optimizing household response to epidemics. What should people do? What works and what doesn't? And is there even anything people can do? This adenovirus simulation, that's something we did recently. It was a senior level exercise where we were, our data was used to set up a tabletop exercise. And then right now we're dealing with MERS, which is the Middle East Respiratory Syndrome. It's something that's just coming up. We don't know how, not me personally, but everybody doesn't really know how it's transferred, what the characteristics of the disease are. So we're doing some work to try and figure that out. So one question is, you have all these antivirals, how should you distribute them? Should the government keep a stockpile and give them out according to some policy? Should you make them available over the counter? Should they be prescription only? And a lot of that goes into having a limited supply and using it to the best effect. If you make it something that's over the counter, people go out and stockpile them. That's generally the higher income people. So you have an income inequality, whereas the government can distribute them without regard to income. So we're trying to figure out what the best way to do this is. And it actually turns out that there's a hybrid approach that is the best, where you make some stuff available over the counter, the government holds back some stockpiles they can use as well. And I didn't put the reference on here, but we have a paper on that. And then, like I said, the early days of the swine flu. So at this point, the transmissibility and virulence of the disease wasn't really known. There was a few cases in Mexico and then transmission from there into the United States. Initially, there's very high mortality, but that could be basically in Mexico, you're only getting the people who are sick enough to actually go to the hospital, so you're not seeing the real mortality rates, only the people who are actually really sick. So we were involved with Ditcher Reachback, one of our sponsors, who was in turn talking to the Department of Health and Human Services at a very high level. And we were the only modeling team that was able to turn results around fast enough. Basically, every morning we got a bunch of numbers from them about where the reported cases were. We did our simulations, gave them results the next morning so that they could go and brief those numbers. We had to greatly scale down the size of the experiments we were running on in order to meet that time schedule. So we didn't do as many cities as we want. We didn't do as many cases as we wanted to. Something I should have mentioned is that we're not trying to make point predictions. We're not going to say, if this happens, exactly 33,456 people are going to get infected. It's just the actual system we're modeling is too stochastic to have that make sense. What we're trying to do is say, under these general circumstances, if you have intervention in A and intervention B, generally intervention B works better than intervention A, so that's what you should do. Or you have 3 interventions, if you layer them in this way and you time them at this point, that's generally the best way to do things. So going back to this, if we had Blue Waters at that time, we would have been able to give them much better results, much more comprehensive results, and I think they would have been much, much happier. Everybody else using Blue Waters might not have been if we were using the whole machine for this stuff, but that's something else. And something we've just started doing is forecasting, basically incorporating social media into our models to try and get better predictions, both of how much influenza is actually out there and what people are doing about it. Are people getting vaccinated? Are they staying home more than they would? Are they washing their hands more so that the spread is going down? And this is kind of the beginning of a 10 to 20 year process where the end goal, what we want, is to have something similar to weather forecasts, where you would be able to go to a website, put in your zip code, and it would tell you over the next few weeks, this is what the flu looks like in your area. In some ways, it's more difficult than weather forecasting. For the weather, no matter how much you want to, you can't affect it. What's going to happen is going to happen, and all we're doing is trying to predict what that will be. For this, like I said, all those things are interrelated. By getting information out to people, you're actually changing what they do and then changing what the spread is actually going to be. So it's more difficult. There's a human issue in there, and also your forecast can change. It's not changing because you didn't forecast it well given the information you had, but the conditions are actually changing. Okay, so let me skip ahead. I just want to mention this. We do have basically a portal for these public health people to go in, set up experiments. Basically, they hit run, it goes off, runs on these big HPC machines, so they don't need to know that what's going on. So the key challenges for this code, it's a large, highly irregular, dynamic network. It changes from day to day as people get sick and change what they're going to do and public policies get implemented. It has a very large number of small messages that are exchanged, so that was something that we had to take care of and do some message aggregation. Luckily, it's not very latency sensitive, so we were able to do effective message aggregation. Like I said, there's a large number of runs that are needed. And this is an atypical application for these very large HPC machines. It's not floating point intensive. Like up there, so less than 1% of the code is instructions are actually floating point. It has a lot of memory accesses and a lot of branching. These were actually from the original code. My grad student, Jae Sung, did a lot of work to get that down as much as possible, but it's still memory intensive and has a lot of conditionals in it. That being said, we were able to scale on Blue Waters fairly well. So this is simulating the entire United States at an individual level for 120 days, basically moving people around. There's 1.5 billion activities per day. So that's how many places people go in aggregate. Okay, so we were able to do that simulation in 12 seconds. And by being able to do it that quickly, that completely changes the type of questions that can be asked and the studies that we can do. And just a note on the granularity, if we do that, we're talking about 800 people per core. So that's a very fine-grained computation that we're doing. We also get just about perfectly flat weak scaling. So between these two, we estimate that we could do the global population in 6-10 minutes, something like that. So the ongoing work, like I said, world domination, we want to do the entire globe, all 8 billion people. We want to add more complex behavior models in there. Currently, there's just basically that we don't model people going anywhere else. It's all travel within their local area, but we want to add a long distance model in there. We already know how to do that. It's just a matter of doing the coding. And that's something that didn't matter when we were doing city or state-based things, but as we've gone up to the entire country, then that definitely becomes more important. We want to add in co-circulating diseases, so something that's important is adding ILI into the mix, which are influenza-like illnesses. They basically confuse the surveillance programs because unless you actually do a lab test, you can't tell whether somebody has the flu or they have something that's like the flu but is not the disease that you're tracking. And we also want to add complex contagion, which is basically, that's more for the social contagion stuff. For influenza, it's all pairwise interaction. If I'm infected, you might get infected, but you don't have any interactions, or it doesn't matter that there's more people in the room because they're all done individually. For social interactions, it may be that you don't start taking up smoking until 5 of your friends do. So you have to basically taking into account all of the interactions that you're doing in order to figure out what's going on. Okay, and I'd just like to acknowledge NDSSL and our collaborators, NCSA, Sanjay Kali, and the Parallel Programming Laboratory. I forgot to mention this was originally done using MPI. Before we moved to Blue Waters, we switched to Charm++, and that actually helped quite a bit. And then people who are funding the model work, NSF, NIH, the Department of Defense, CDC, and HHS indirectly. And I'll just end with this movie that shows the spread of disease through New York City. The 4 panels are basically just successfully zoomed in areas, and it takes a little while to get going. But while that's playing, I'll be glad to answer any questions. Yeah.